Okay. Okay, let me just check microphone. Mm, built-in microphone is there. Shall I refresh? Yeah, can you hear me now? Is this audible? Yeah. Hello? Okay, go ahead then. Thank you. Thank you. I'll start again. Good evening. I'm Dr. Srinivas Thati, Consultant Orthopedic Surgeon with special interest in joint replacement surgery and sports injuries. I work at AIG Hospitals, Gachibowli, and also Medics Healthcare at Nanakram. Thank you all for joining me today for this session on hip fracture in elderly and its optimal care and treatment. At the outset, I thank Dr. Sujit Punnam and also Click2 Clinic team for giving me this opportunity. The reason I choose this topic for awareness is we know we are going through a tough time with the COVID. When we look at orthopedic trauma, there is significantly reduced trauma all over the country, across the world. However, there is no difference in the incidence of hip fractures. When I compare the treatment protocols which are followed in the Western world and those followed in India, there's a significant difference in the outcomes and also morbidity and mortality. I have been in India for the last 2 years. After working as a consultant in UK, I returned 2 years ago. In the last 2 years, I have seen a lot of variations in how these fractures are managed. When I looked at the literature, in the medical literature, I could not find significant studies which are done in India. So I thought it will be a good topic to discuss on a public platform so that the awareness in general public is improved. I would like to say a disclaimer. This talk is not sponsored by any of the pharmaceutical companies. It is purely my interest in the topic. I'm going to give an outline of what hip fracture is, how do they happen, how does it affect the general mobility, and also the risks associated with the hip fractures, the treatment options available, and what are the best treatment options, how will be the recovery, and how we can prevent these fractures. When we look at the statistics, 20% of people in our country are over 60 years. Government of India defines elderly or senior citizen as anyone above 60 years of age. And the incidence of these fractures is around 6 lakhs per year. It means we see around 6 lakh fractures in the neck of femur every year in India. The associated mortality is around 42%, which is quite significant. In 1823, a famous English surgeon said, "We come under the brim of the pelvis and go out of the neck." That is by Sir Astley Cooper in 1823, nearly 2 centuries ago. And at the time, the quoted mortality of hip fracture is 75%. At the moment, in India, from the crude studies we have, the mortality, that is rate of death with the hip fracture, is around 42%, which is quite significant. When we look at the Western society, their mortality rates are going down because of the protocols they are following. So, in the elderly, hip fracture is a commonest serious injury. It is one of the commonest cause of accidental death, and it is the commonest reason for an elderly person having emergency anesthesia and surgery. The outcome of hip fractures are seen as a marker of modern healthcare in the Western society, and I passionately believe that this will become the case in our country as well with improved outcome measures. So, what is hip? The hip joint is formed between the pelvic bone, which is like this. Okay, the pelvic bone has a socket, and the ball of the thigh bone together form the hip joint. It is very important in movement of the joint and also in weight bearing and walking. The neck of the hip is between the ball of the thigh bone and the shaft. It is the connection. This is the neck of the hip. The fractures usually happen around this area. In relation to the capsule of the hip joint, we divide them, or basically typically describe them as either intracapsular, that means those which lie inside the lining which grows from here to here. If the fracture happens from under the ball down to here, it is called an intracapsular fracture. If the fracture happens outside this line, it is called an extracapsular fracture. Why do we divide these like this? Because the treatment changes when we find where the fracture is. So how do we know that the person has a fracture, or what are the common modes of injury which results in hip fracture? Majority of the time, the fractures happen domestically, that is within the house, and often because of slip and fall in the wet washroom or in the floor anywhere in the house, or when an elderly person trips over a step or misses a step. Some of them can have a fall in the night when it is dark and they knock over the furniture as well. Some patients may have blackouts, and particularly when they're on medications which can lower the blood pressure significantly, or when they rise from lying down position, the blood pressure may drop suddenly. That's why elderly persons always should inform them to rise from lying down position slowly so that their blood pressure suddenly doesn't drop. That we call as postural hypotension. Even that can also cause the fall from standing position or standing height and cause a fracture of the hip. Road traffic accidents can also cause fracture of the hip, but they are less common than what we normally see. So how do you know that the person has a fracture or not? The first symptom you'll notice is the patient will have pain in the groin. They will not be able to weight bear on the leg which is injured. The leg may look deformed and the foot may turn outwards. The leg also may look a bit short. Slowly they may develop some bruise or swelling around the hip joint. These are the typical symptoms and signs of a hip fracture, which we will not be missing out. Once the person is found to have an injury and you're suspecting a hip fracture, what we need to do immediately. The immediate treatment or immediate assessment is very important. If you're with the person or if the person is all alone, they have to try and stay calm. They should be reassured. Check if they are conscious or not. These fractures may be associated with head injuries, and it is very important to know whether they have knocked their head or injured their head, particularly in patients who are on blood thinners. Blood thinners are given in elderly with heart diseases or those who are at risk of stroke to prevent clots. And if a person is having this medication and had a fall, we should definitely rule out a head injury. Once you check the conscious level of the patient, check if they have any other injuries. Try not to move them immediately. If you're all alone and can't help the person, please call for help and call for an ambulance. These are the important things which you do immediately. There is no need to get panicked. Please reassure the person and reassure yourself that everything will be okay when you take the right measures. So, when I say optimal care, what is optimal care in treatment of hip fractures? In the UK, the National Institute of Clinical Excellence, called NICE in short form, has given certain guidelines in treatment of hip fractures. And these guidelines are followed explicitly by entire country, all the hospitals. And this is being followed by a national audit. It's called National Hip Fracture Audit, or a database is maintained with these fractures. And what they found is when the optimal care standardized protocols are followed, the outcome of hip fractures and the mortality have significantly come down. So that's where I say this is optimal care. So we need to have a standard protocol for treating these fractures in every hospital. The hospital is better to have a dedicated hip fracture service, especially the tertiary level hospitals. By doing that, we can improve the outcomes significantly. And that certainly gives an opportunity to produce good research as well. All these patients who have hip fractures need to be prioritized if you're planning for surgery. Give a certain specific time. They're best done first thing in the morning than leaving these fracture patients for later in the day. There are several doctors or specialists need to be involved in the care of the neck of femur fracture patient. The most important person will be, of course, orthopedic surgeon who deals with these fractures. Then the physician who has special interest in care of the elderly. In the emergency room, the emergency physician is very important in early optimization. And certainly, anesthetists with great skill in dealing with these elderly patients is also very important at the time of surgery. Not only the doctors, it is also important to have good nursing care, because nurses are the ones who are going to watch or see the patients round the clock. And it's important to have nurses who are trained in dealing with group of patients who need more support at the time they are admitted from the time they are discharged. Along with the nurses, we need physiotherapists. Physiotherapists are very important in early mobilization, helping these group of patients to ambulate. Once the patient starts walking with the help of a frame, then they can be gradually allowed to improve the general strength and balance. In this, the physiotherapist plays a major role. Along with the physiotherapist, a dietitian is also very important, because the diet pattern of these patients can be very poor. They may not have adequate proteins or energy levels. and they may get dehydrated very quickly. A dietitian plays a major role in getting these all in a perfect protocolized. So it is very important for treating these patients under the umbrella of a multidisciplinary team, which involves all these doctors, the specialist nurses, the physiotherapists, and the dietitian. Not only the professionals, it is also paramount that the family takes a big role in supporting this group of patients because they are the major decision makers in our country about the treatment of these elderly. So I would say family support is equally important than any other professional help. Once we know that the patient had a fracture, when we take the patient to the hospital, what happens there? This is very important for the general public to understand. The patient will be taken straight to the emergency department. First, in the emergency department, they will be optimized. Once the diagnosis is made, the concerned department specialists like orthopedic surgeon and physician will come and see the patient. From the emergency department, the patient will be admitted into the ward and then optimized for the treatment. The treatment in majority of the cases would be surgery. And then the plan for surgery, the anesthetist will come and see the patient once the necessary investigations are done. And then the patient will be taken to theater in a day or two. After the surgery, they'll come back to the ward. They may need to stay one night in the ICU in places where there are facilities or in high dependency units in the periphery. Once the patient is back to the ward, they can start mobilizing under care of the physiotherapist. Majority of the times, the patients will stay in the hospital for around 4 to 7 days. Once the patient is able to manage themselves up to the washroom, they can be discharged home. In some cases, they may need to go to intermediary care. In India, we can see nowadays developing intermediary care. But when in Western society, majority of the times, the elderly with these fractures will go first to intermediary care and then to their own home. So what happens in the emergency room once the patient is taken there? The initial assessment is done by the emergency doctor to see how the vitals are, like blood pressure, temperature, heart rate, saturations. All these are important. Once these are checked, then they'll do a specific assessment to see how the limb is, where the break is. And once that is done, the patient will be given painkillers, start off with some IV fluids so that they don't get dehydrated, and then plan for an X-ray. X-ray is a very simple investigation, and in majority of the times, I would say 98% of the times, will show us if there is a break or not. However, in those very small group of patients where the fracture is not clearly seen, we may have to do an MRI or a CT scan. MRI is preferred over a CT scan where the facilities exist. Once the diagnosis is made of the fracture of the femur, then we have to start optimizing the patient for treatment. So the first thing we do is to get all the basic blood checkup or workup. We do an ECG, chest X-ray, and when the surgery is planned, we have to do a 2D echo to make sure the heart function is good. When all these are done, the patient can be transferred to the ward. Majority of the times, as per the guidelines, patients should not be spending more than 3 to 4 hours in the emergency department. That is as a guideline by the NICE. So once the patient is back to the ward, then we know that the patient has a broken hip. We know whether it is broken under the ball or the extracapsular at the shaft and neck junction. That would be able to decipher from the x-rays. So, what are we going to do about this next? Can we treat the patient without the surgery or with surgery? There are a number of traditional treatments available in India, and majority of the patients still go for the traditional bone setters. Unfortunately, the complications associated with non-operative treatment are quite high. Why do these complications happen? Mainly because the mobility of the patient is significantly reduced. In fact, they'll have even difficulty in performing their natural, I mean, passing urine or opening bowels can also be very difficult because any movement of the limb can cause pain. Pain can create a lot of stress and that can have other effects. And if the patient is not moving out of the bed or not mobile, the common complications we see are chest infection. That is the commonest complication we see. They can develop bed sores in the back, lower back, or we call this as sacral bed sores, or over the heels. The bed sores can cause significant issues in terms of feeling, risk of infection, etc. Some patients do develop urinary tract infections, and it is more common in women than in men. There's a risk of clot formation in the legs or the lungs. If the clots are formed in the lungs, they can be life-threatening. Some of the patients can become confused. They may lose the diurnal variation if they are being indoors all the time. And their functional outlook will be very limited, and some of them may go into depression. When the patients are treated without surgery, the risk of death is very high. It is around more than 40%. Hence, the best treatment option for a patient with neck of femur fracture is surgical management. I'm not selling surgery here. I'm telling this from the lot of medical literature available, and I can clearly tell you that this is not from the pharmaceutical companies. This is from the large national hip fracture database, not only in UK, it's from US, Australia, many of the Western countries have these. So once we decide on the treatment, and I am proposing a surgical treatment for all these group of patients, unless they have comorbid conditions which can put their life at risk with surgery. That is the only contraindication I would say for this group of patients where the treatment is ideally surgical management. Time to surgery is very important. Once the patient is admitted and optimized, as per the guidelines, if the surgery is performed under 36 hours, or we can say a window of 24 to 48 hours, the functional outcome and mortality, morbidity are very less. When I looked at literature or the papers, research papers in India to see what are the causes for delay in India, there's a very nice paper written from Odisha, which has used the 3 delay model. The 3 delay model is when the first delay happens in making the decision whether to take the patient to hospital or not. Majority of the times that is very common in India because the decision maker is usually the family than the patient, and it is very important for the family to understand this factor. Okay, that's the reason why I would like to stress on this. The first factor, decision making, is very important, in this group of patients. Early decision will make their outcome better. Once it is decided to go to the hospital, the second factor for delay here is the transport. Again, I keep going back to the Western society here because that's where I have seen these fractures more. The transport is by the National Health Service in UK. Majority of the times the patient will be to the hospital from home in 2 to 3 hours or even less. But unfortunately in our country, particularly patients who are deeper in the rural areas or in the towns, they may take a longer duration to come to a specialty hospital where these fractures can be treated. That is the second delay for bringing the patient for treatment. And the third delay is the availability of the service once the patient is admitted into the hospital. Not all hospitals are equipped. In the metro cities or major cities, yes, a lot of corporate hospitals, the teaching hospitals, the private healthcare sector will have these facilities available. But when it comes to towns and rural areas, yes, in the primary health centers, they may not have these facilities. In the towns or district headquarter hospitals, not all are equipped with these surgeons who can treat these fractures. And hence, that is the usual third delay we have seen from these papers. And to my knowledge, what I have seen here is cost is another big factor. Certainly, the state facilities, the hospitals which are sponsored by the governments, they do have no cost implications. However, in the private setup, the cost is a major issue for middle class people to get this treatment. I hope that the government take measures in improving these delays so that these group of patients can get better treatment. So once we decide the treatment, surgical treatment, depending on the type of fracture, there are different options. If the fracture is under the ball of the hip, like in that area, and there's a collapse of this, we call this as valgus impacted fractures, which are fairly stable and undisplaced. In these fractures, we can do treatment with simple fixation. I'm going to show you some pictures here. So you can see this, if you can see, that is the area where there's a break on the neck of femur. And treatment wise, what we can do is we can use these 3 screws. If you can see, that is a simple way of treating the valgus impacted fracture neck of femur. If the fracture is moved out of place, like where, if you can see this, so if you can see on this side, the ball here is moved out of place completely. And these fractures need the head removal. Either we can do a half hip replacement where the ball is only changed, or a full hip replacement where the cup and the ball need to be replaced. In patients who are younger, who are community ambulant, that means who walk without any problems in the community, without any supports, and they don't have any other comorbidities, these group of patients will benefit from a total hip replacement than a half hip replacement. In patients who have extracapsular fracture, that means the break going around this area, not under the ball. If the break is going under this area, the treatment depends upon the extension of the fracture or how far it is displaced. So this we call as a dynamic hip screw, where we put a plate and the pin into the bone. If the fracture is displaced quite far away, we can do a rod going into the bone and pin going into the ball. This we call as cephalomedullary nailing. So these are the surgical treatment options. Majority of the time, the surgery takes around 1 to 1.5 hours under anesthetic. The preferred anesthetic is usually uh, spinal anesthetic, and we should not be worried that spinal anesthetic will cause back pain. No, it's a very small needle going into the spine. It has major benefits when done under spinal anesthetic. The blood loss will be less, the pain control is very good, and the patient will be awake. There will be no side effects as we see in general anesthetic. So, ideally, the patient can get surgery done under a spinal anesthetic. So, to repeat, if the fracture is under the ball, if the fracture is under the ball and if it is impacted, we can do 3 simple screw fixation. However, if the fracture is displaced, that means the ball has moved out of place, then we may have to replace the ball. In younger patients who are physically very active, in those patients we may have to do a full hip replacement where we change the socket as well. In patients who have a break in the neck here at the junction of the shaft and the neck, these patients can either be treated with a pin going into the bone on the outer side, or a pin going into the canal of the bone, which we call as a cephalomedullary nail. Once the surgery is done, then the next stage would be to rehabilitate the patient. The main reason for the surgery is 1, to improve the pain. Number 2, to improve the mobility of the patient. When I see this group of patients who come into the hospital, the first question majority of the family asks is, how long does the patient need rest? In this group of patients, the resting in the bed is not a good idea. It is very important for mobilizing the patient. The first reason why we suggest surgery is to make the patient mobile. Being in the bed can cause all the complications which I said before, like chest infection, urinary infection, clots in the legs or the lungs, bed sores, etc. These need to be prevented. That is the whole idea of proposing the surgical treatment. So once the surgery is done, my patients in my practice, I make them walk on the day of surgery, fully weight bearing. Again, there is a difference in opinion. Some surgeons would like to say the patient can put only partial weight, but when we look at the studies again, those who do full weight bearing, they have good chance of healing quickly. So on the day of surgery, we can get the patient out of the bed into a chair and can make them walk with the help of a frame. Once the patient is back on the ward, with the help of the physical therapists, the nurses, and also the family, the patient need to be mobilized more often than less. Mobility not only improves the pain and healing of the fracture, it also helps in getting the patient back to their normal. You don't want the person, elderly, to feel that they are dependent on many. We should bring them to be independent as soon as possible, where they can walk from their bed to the washroom without any help. In the beginning, this is very important for the elderly person. That will help them in keeping their belief in the system. Otherwise, depending for taking their natural calls is quite demeaning for any person. That's where it is very important to get this group of patients out of the bed and start them mobile as soon as we can. So, majority of the times, as I said, the patients will remain in the hospital for 4 to 7 days. We usually remove the sutures around 2 weeks' time. Nowadays, I do only subcutaneous absorbable sutures so that we don't have to bring back the patient. Because of the COVID situation, I don't want to take this risk of getting the patient back and forth to the hospital. I would rather have the patient at home. I can do a video consultation with the patient, check the wound on video. If there are majority of the times there won't be any issues, then I'll see them 6 weeks later. If the break is extracapsular, these patients may need follow-up X-rays to see how the implants are, how the fracture is healing. When it comes to complications of hip fractures treated surgically, there's a small risk of infection, which can be less than 1%. There's a risk of failure of the metalwork, especially if the bone is very soft. We got to be very careful what we choose to fix the fracture with. The legs can swell up. The swelling can be there for 3 months. That should not be worrying, but we should be regularly checking if there's any clot in the calf or not. This is very important. If there's any clot in the leg and if that goes into the lungs, that can be life-threatening. Hence, as a preventive measure, we give thromboprophylaxis. That means blood thinners into the skin. The proposed duration of blood thinners is around 4 weeks in UK. I follow that to a certain extent here. I give for 2 weeks. So far, I haven't seen any deep vein thrombosis or pulmonary embolism in the patient groups I treated with these fractures. Once the patient has been discharged, it is also important to make sure that we do an assessment to prevent further falls. That falls assessment should be done within the hospital. It can be done either by the orthopedic surgeon, physician, or the physical therapist. The falls prevention program is very important in these group of patients. Not only the falls prevention, we have to check the balance, how well they are walking, how is their balance when they are walking, how the bone quality is. If they have osteoporosis, we have to treat them straight away. In elderly patients, as per the guidelines given by osteoporosis groups in Western world, they say if the patient has a fracture of the hip and the bone is soft or osteoporotic, we don't have to do any DEXA scan or bone mineral density scans. We can start straight away the treatment for the osteoporosis. There are other important preventive measures in prevention of these injuries. Number one, avoid slippery floors, particularly at home and in the bathroom. Now we got tiles which are anti-slid as well. Maybe a good idea to get access to these. Or you can give a carpeted dry washroom. That also helps in majority of the patients. Provide well-lit washrooms so that the patient will not have any fall because of low visibility. We have to remove the trip hazards like any obstructions in the path of their walking. As I said before, the patient should be encouraged to rise slowly from lying down position or sitting position so that we can prevent postural hypotension. Some medications can cause dizziness. We have to make sure these are regularly checked, particularly antihypertensives. Sometimes in the elderly, we may have to change the dosing, and it's always better to check with the physician. And periodic assessment of the blood pressure, postural hypotension is very important. In patients who have diabetes, sudden drop in the blood sugars can also cause falls, particularly those who are taking insulin. So we have to make sure that the sugar levels are optimized as well. When we look at the specific measures to prevent falls, always get these elderly patients eyesight checked so that they won't fall over the because of lack of visibility, particularly during the night time. A lot of patients, when I ask them to walk with support, they feel a little taken back. But I would say it is very important to encourage the patients whose balance is not that good to use the support, like a single walking stick. Those who have very much limited mobility within the doors, maybe they can use two sticks or a frame. All the patients should be encouraged to strengthen the muscles, all the core muscles, upper limb muscles, lower limb muscles, some simple exercises. The physios can help in doing this to improve their general mobility. And the physios can also help in improving the balance of the patient. So, to complete my talk, I would say hip fractures can have significant morbidity and mortality. I'm not trying to scare anyone here. I'm telling this from evidence all over the world. So I hope this talk has given some take home points. The main take home points would be hip fracture is a very common serious injury in the elderly. This has to be addressed as soon as possible, ideally within 48 hours after the fall. In majority of the cases, surgical treatment will give the best outcome. In patients who have osteoporosis, they need immediate treatment for the osteoporosis. The patient should also be assessed for false risk. It's very important to make sure all these steps are taken. And I would reiterate that surgery is the treatment of choice in this age group, unless and otherwise there is a significant comorbidity which can put the patient at risk. I hope I have covered majority of the general questions asked about hip fractures, and I would try to answer any questions if we have. So one question by Mrs. Rachna Srivastava is, does a person need a surgery even if it is a hairline fracture? Thank you, Rachna, for asking this question. Yes, it is a very pertinent question. In a hairline fracture, how are we going to make a decision whether the patient needs surgical or non-surgical treatment? This will be based on one, examination of the patient, two, how the x-ray looks like, where the fracture line is. If on examination the patient is able to lift the leg straight up without any difficulty when lying down on the bed, and if the patient is able to take a little bit of weight on the leg with the help of support, then these hairline fractures can be treated non-operatively because the mobility is not impeded, and if the patient is able to manage the pain. However, if this hairline or undisplaced fracture makes the patient immobile and the pain is not controlled, which is also affecting their day-to-day activities and attending their natural calls, yes, it is a good idea to think about surgery. There is no ambiguity here. It is very clear. If the patient can keep themselves mobile with some amount of support, yes, we can try or trial non-operative treatment. If the patient is not able to be mobile, not able to do their day-to-day activities and attend their natural calls without help and not able to manage pain, this group of patients would need surgery. The other group of patients in hairline fracture where they need surgery is, when we look at this ball, if the fracture line is going straight down, like that, straight down, then when the patient starts putting any weight on this, there is a risk of displacement. This we call as shear fractures. in the mid-cervical region. These fractures are at high risk of displacements. We can definitely try a non-operative treatment. However, if the patient is not able to, as I said before, they did perform day-to-day activities and the pain is really bad, then they would need surgical treatment. The next question is from Saloni Sharma. How is weight gain or weight loss related to hip fractures? Thank you, Saloni, for asking this question. Certainly, weight is a big factor. Majority of the patients who are overweight, this is very interesting, please listen carefully. The two types of fractures I told, the intracapsular fractures and extracapsular fractures. The intracapsular fractures are commonly seen in low weight persons, when the body mass index is very low. The extracapsular fractures are seen more often in patients who have high body mass index, as a general rule. However, when it comes to the treatment, whether they have low body mass index or high body mass index, they need surgery if they are affected with mobility and pain. I hope that answers your question. Next question is from Deepika Khanna. What supplements are best for elderly to ensure healthy bones after they turn 60 years of age? Thank you, Deepika, for asking this question. As I said, majority of these fractures, I would say almost about 95% of these patients, in elderly patients, they do have a pre-existing osteoporosis. And bone health is very important in preventing these fractures. If the patient has certain symptoms like generalized body aches, aching in the small joints, low back pain, feeling fatigued easily, all these are come under osteoporotic kind of symptoms. So it is better to get an assessment properly by an orthopedic surgeon or a rheumatologist to see how the bone mass index is. So the simple way of doing it is bone density scan or DEXA scan. That will give us a number, which is a qualitative figure. Based on this, we can tell whether the patient needs any intervention or the general measures are adequate. Your question, the general measures, the supplements the patient need to take. One, they have to take vitamin D, which is very important. Vitamin D, either they can take regularly along with calcium, or just vitamin D and they spend eating a lot of food which is rich in calcium, like nuts, eggs, green leafy vegetables. There's so many you can look up. Taking calcium supplement, sometimes some patients ask, does it cause kidney stones? Again, this is a misperception in majority of the public. By taking calcium supplement, you're not increasing the risk of kidney stones. And in patients, elderly patients particularly, you can take the calcium supplements regularly. So vitamin D, calcium supplements, B12, having adequate protein intake, these are all important for bone health. Not only this, regular activity is also very important. The bone is a tissue, which it is a live tissue. It will be stronger when you are loading it. If you are not using the bone or even the muscle, the bone mass or the muscle mass will go down. If the person is not using the muscles for say even 2 weeks, they may lose significant amount of muscle mass. Particularly in the elderly, it is even more. So it is very important to do loading activities like walking is very good. They can walk as much as they can manage. Simple exercises like aerobic exercises will help in keeping the muscle mass, muscle strength. You can do static cycling safely. Treadmill is also okay. if they don't have any problem with the knees or the hips. And stretching is also very important in keeping the joints flexible. So these are all the general measures which you can take to prevent uh, weakening of the bones and be prone to fracture. And another question by Deepika Khanna. Also, after a lot of loss of weight, I need to stand up every 10 minutes, and sitting for long gives me pain in the hip area and makes me uncomfortable. Does it indicate the hip bones are weak or fragile? Um, it's a good question, Deepika. Um, Loss of weight by itself will not cause weakening of the bones or muscles. However, we got to see how you have made this weight loss. Did you manage it by restricting your diet or by your activity? If you managed it by restricting your diet, did you take a balanced diet or not? So, as I said before, it is very important when you're losing weight, please take a balanced diet. You have to cut down on the amount of volume of diet you take, but at the same time, you need to take appropriate nutrients as per the daily allowances. That's why it is very important to meet a dietitian, especially when you're planning to lose weight. Traditional weight loss programs are there. However, when you have the opportunity to know exactly the way you can do it more scientifically, I would say use that opportunity. And to answer your question, if you're getting pain around the hip area or in the lower back after sitting for a while, yes, certainly you need a proper assessment to see where the pain is coming from. Is it coming from the lower back? Is it coming from within the hip joint? Or is it mainly because of the tightness around the tissues? And majority of the times it is to do with the tightness or lack of flexibility or weakness in the muscles. So you have to work up to improve your core muscle strength. So please see a dietitian and also a physician who can answer this question. And it may be appropriate to see a physiotherapist and seek their help in improving your core muscle balance. Of course, once the code is improved, that's when I would suggest to do this. And the next question from Sharda Praveen. Thank you, Sharda, for asking this question. How to manage osteoporosis? I think I have already answered this question. I hope you got the important points. Thank you. Next question, should people with vertigo can go for the hip replacement surgery? Um, Thank you, Nida Ali, for asking the question. I know this is out of the topic. However, hip replacement surgery is a safe procedure, and a vertigo as such is not a contraindication. You need a thorough assessment at the time of having this surgery to see how your vertigo is, how severe is your vertigo. There are certain precautions you need to take after the hip replacement surgery, particularly to prevent dislocation. If you're planning that, please discuss with your surgeon in detail. But vertigo as such is not a contraindication for hip replacement surgery. And another question by Nida. Can a patient with post-burn contracture on finger should opt for surgery to release the contracture? I know this is out of the context again, Nida, but to answer your question, yes, if it is affecting your function, particularly the hand is very important. The fingers can, when there is a contracture, they can come in the way of doing activities. Yes, please consult appropriate hand surgeon. They should be able to give you the required information. I hope you have all enjoyed this live session, and I have hopefully I managed to answer a lot of the questions, and I have taken up this session with a passion to create awareness on hip fractures. I wish our elderly also receive the same kind of standard treatment which the Westerners are having. and we improve the outcomes, not only the morbidity associated with these fractures, but also reduce the mortality associated with these fractures. Please feel free to contact me through our website or through Facebook, where I'm available, or through Click to Clinic, and will be more than happy to answer. If you have any long questions, you can email me on our Medix Healthcare email ID, which is medixhealthcare1@gmail.com. Thank you very much for all the team from Click to Clinic who has done a major effort in getting this program onto the stage. And I wish you all a happy weekend and take care. Bye bye.